Hello, everybody, and thank you for joining us for our August 2020 edition of our show. We're here to further discuss the coronavirus, the COVID-19. We are deep in the pandemic, so we are still practicing our social distancing. So we are not wearing our masks today because we are not in close proximity of anybody. Thank you, Dr. Fazil, for joining us.
Thank you, Wendy, for having me on this show today, and thank you everybody to watch our show. So the topic of the discussion, as Wendy said, is what's next in pandemic of COVID-19 pandemic, and are we out of the woods yet, and what are the what does the future look like? So Wendy, what is your do you have any question in mind so we can start the conversation?
Yes, actually, Dr. Fazil, what we are questioning is, what is the new standard of care for this COVID-19 virus?
So I think you're trying to ask what is the standard of care for the treatment, or what is the standard of care for the diagnosis, or what? Can you please explain your question a little bit more for me?
Yes, what would the standard of care be for the current treatment for COVID-19?
So this no published standard of care for treatment of COVID-19 infection is this time. As a matter of fact, we do not have any consensus on the treatment of COVID-19 infection. I can tell you what I'm doing is that we only treat patients when they have symptoms, and once we know patient have COVID-19 and they have symptoms, which could be respiratory tract infection like symptoms like cough, runny nose, sometimes they have diarrhea, sometimes they have fever. Also they all present with loss of smell sensation as well as taste sensation. So, and then if they have a high risk exposure to COVID-19 infection, then with the symptoms, you'll probably know that they have active infection going on. So besides doing the quarantine for 15 days as suggested by CDC, I would also treat them with steroids, which is prednisone, which is kind of equivalent to what dexamethasone is being used in hospitalized patients, as well as with Z-Pak, zinc, and hydroxychloroquine. I know that hydroxychloroquine is a kind of like more of a political dilemma at this time. I think between different visions of our political sector is being looked upon as a taboo, I guess. But when you have a very, very sick patient in front of you, we're gonna do what need to be done to save lives, and in outpatient setup at this point, that's all we got. And obviously we do take precautions. I know hydroxychloroquine can cause some connection delays in the heart. That's why you do an EKG before you start using it, and you're probably not going to use that in anybody who have underlying heart condition, especially the electrical connection defects. But the benefit is more than any risk there might be. So that's what I would follow at this point. There's some studies which supports in favor of its use, although they're not very big studies. But again, we're going to use what we need. We have in our hand at this time in outpatient setup. Inpatient setup, you have remdesivir, you have dexamethasone, we have the convalescent plasma infusions, as well as if they are getting really short of breath, bring them on the ventilator. But my suggestion is, why wait that long where patient gets sick that enough to get to that level? Why not treat them early enough and even prevent them the hospitalization? Because the more infection and inflammation they get, difficult is going to be to treat them. And that's what my take is on this epidemic at this point.
Thank you so much. Dr. Fazil, in your clinical experience, have you had positive outcomes with that regimen that you were just discussing with the hydroxychloroquine?
Yes. So in my clinical setup, in my clinical practice, any patient who have a suspicion of having COVID-19 infection based on their exposure as well as symptoms, I have seen a very good response so far. None of my patients have actually got admitted to the hospital, and typically 5 to 7 days of treatment have make their symptoms go away. And I have a patient who was 70 years old, came to me. He was COVID-19 positive, and obviously besides doing all the isolation and everything else, you still have to treat it because he was sick, but not sick enough to go sent to the hospital. But he did have underlying comorbid conditions like asthma and COPD. So I went ahead and treated him with the regimen we know that might work, and it did work. And 7 days later, the patient was almost jumping with the joy, and he said he had no symptom at all, and he was totally asymptomatic, and it was like a miracle.
Thank you. Dr. Fazil, we've seen a huge surge in positive cases throughout the United States. Is there anything that you can add to that or elaborate on to kind of explain why we're having so many positive cases?
So that's a very good question. So the fact of the matter is that our healthcare system is driven on fee for service versus a lot of other healthcare system in other countries. They're more of a social medicine. That means this some part more tests is being done than other countries because the labs get paid pretty heavily by insurance companies. So that's one thing. The second thing is obviously the more tests you do, the more cases you're going to get. And also I have seen that if the patient is tested twice, for example, he got tested one time and then 2 weeks later he wanted to test again to see if he has recovered, and if he's still positive, that is being counted 2 cases. So the data is skewed, and we can I think that's one of the reasons that we are seeing such a huge like a spike, unusual spike in United States as compared to other countries. And I know that a lot of countries not even checking it anymore. They wouldn't even check it unless they think that you need to go on the ventilator. So now they don't even have a data. Well, if you don't have a data, if you don't check it, then it seems like they got a plateau in their cases, which is not true. And I know some of the countries are doing it for financial reasons because they want to make their countries look better than the United States, because that's going to help their tourism business and everything. So I think we have a disadvantage by giving the true numbers in one way, which is right thing to do, but also it makes the numbers looks bad. And also we have a lot of false positive cases as well. And what I would suggest is, if you want to really look at the real numbers from other countries versus our country, United States, then look at the mortality rate. Our mortality rate is very low as compared to a lot of other countries, developed or underdeveloped countries. And if you look at the data of the death rate, the death rate is pretty high. But then the death rate from other countries, you don't know if they die of COVID-19 infection or something else because they got never tested for that. So the whole it's like comparison between apple to oranges. So what we're doing is we're doing more, but then we're also getting nailed for that as well. So I think that's where the problem is. Too much testing, data which is defined differently than what the conventional wisdom will tell us to how to define the test, and that is like making our case look way too high.
So Dr. Fazil, where can the average person look to for accurate information and instructions? There's so much information out there, and sometimes it's controversial as far as how accurate or inaccurate the information may be.
So for the information, obviously the internet has a lot of misinformation. There's a few places that the consumer can go and look at, like CDC website for guidelines, as well as they can ask their primary care doctors, which are pretty well aware of the new development in the COVID-19 infection. So I would rely on those two places, at least for now. We'll see in the future, but that's more likely you're going to give real information, unbiased real information.
Okay. And if a patient tests positive for COVID-19 and is unable to work, if their symptoms have passed and they are no longer showing symptoms, how soon can they return to work?
We are in uncharted territory at this time. If you look at the published guidelines, they say if you've been quarantined for 15 days after you get positive and you have no symptoms, you don't need to be. You probably can go back to the work. But in a high-risk profession, for example, the healthcare sector, where they're exposed to patients which have more comorbid conditions, my recommendation would be to test them again and make sure they are not still having a positive infection, because they can spread to the patients. So again, that's my view, and we'll see if it changes, because we don't have enough data to say yay or nay on this question at this time. So I will go with, conventional wisdom is to check, and if they got immunity, then they should be good to go. But if they have active infection, they should still avoid contact with sick patients, so they don't get infection from them.
Okay. And where does that leave an employee who is not feeling sick but is still testing positive, or has to wait several weeks for a test results to come back? Where does that leave them as far as how do they support themselves and gain an income, because they are still technically employed, but they're not able to work and they're not able to collect a paycheck?
And that's questions for the legislators. Somewhere they have to come up with some kind of a law that will that a government should fund, or there should be a stimulus package or some kind of system where those employees which are not laid off, but they got infection, and then they are unable to work because of positive infection, but they have no symptoms at this time, but they still have positive tests, then we don't know how long they're going to stay positive, because everybody have different immune response. Then I do understand that they have to have some source of income, because they cannot apply for unemployment, and they cannot get a stimulus check at the same time. Then there should be a third option. I think that's up to the legislator, that they should look into that also, that portion of the employees which are in that undefined category.
Okay. And Dr. Fazil, if an employee has tested positive, or if a patient has tested positive and needs a follow-up test, what is the best test to do? Would that be the nasal swab or the blood test?
So I would recommend the blood test, because what the blood test will tell you is what kind of antibody response you have. Now, if you have IgG antibody for COVID-19 and IgM is negative, IgM is the one which is indication of active infection, versus IgG is indication of immunity. Then you, the physician or the providers, have a better understanding of the situations. So I will recommend the blood test instead of nasal swab, to see if they're able to come back or not. But there's one caveat though. I have seen the reports from the labs where the patient have IgG antibody level positive, and they're writing the interpretation as a positive test. That's actually very misleading. It should say a patient is immune to the test. It should say the patient is immune to the virus and not have active infection because they only got IgG antibody levels positive. So they shouldn't be. The interpretation should say immunity to COVID-19 infection, not saying the test is positive, because that's causing a lot of panic situation in the community. And I think that's another reason we have so much positive cases, because even IgG test positive is being reported as positive test, which should be reported as immune to COVID-19. So that's another reason that we have so much positivity in test results in the United States.
Dr. Fazil, how long are the antibodies present in the blood system?
So after the infection, what we have seen in some of the cases that the antibodies start to taper off after 90 days. So it's very scary, because unlike a lot of other infections where the immunity at least lasts for a year or more, sometimes lifelong, it is not lasting that long. So that's why the herd immunity has probably a less role in prevention of this pandemic, because your immunity is not forever. It taper off rapidly, and we have seen that people who got COVID-19 infection one time, they're also getting it the second time, especially after 90 days when they have lost immunity. And we're also seeing that this virus is mutating fast, just like in HIV virus. And the same thing happens in HIV, that you find a treatment, then you try to fix it, and by the time you got the treatment, it has already mutated, and that treatment is no more effective. So that's one of the problem we are have to face with this super bug. I will call it super bug, which is very, very strange and is rapidly evolving. So it's always one step ahead of healthcare workers and healthcare industry and all the intervention we were trying to put in place. So it is like a super bug, and we're still trying to understand like how to handle this virus, and we'll see what happens in the future.
Okay. What determines the length of time that the antibodies remain present in the bloodstream? Is it the severity of the virus? Is it the severity of the case that the patient has, or what exactly does determine that?
We don't know that. We don't know at this point. We don't have enough data to answer this question. So I think on that note, also I would say the role of vaccine, because most vaccines are designed that you give an immune response to the you give a you have either a virus antigen or attenuated virus, or like a weak virus to the patient, or like a live weak virus to the patient, so they can develop the antibody response to that virus, and they can so they have immunity and antibodies, so when they get real infection, they don't get sick, or they don't get infection at all. But what we're seeing now, that even when they get real infection, the immunity doesn't last more than 90 days. So the question is how the vaccine is going to cause that protection if the immunity only lasts for 90 days. So that's one question we have to answer. And the second question is, if it's also mutating so fast, then the virus will mutate by the time we have vaccine for one strain, what we're going to do for the second strain and third strain. And we also have noticed that unlike the previous prediction that this infection will not be that bad in the summer, how come it's more worse in summer than the winter? And as we know, like flu virus and a lot of cold viruses, they only become prevalent in the winter time. Like for example, a flu virus, it become prevalent from October till November, or October till April each year. So how come this virus is still there in the extreme heat of summer? So that means that this is a year-long epidemic, it has no seasonal variation. That's also very concerning as well.
Okay. So we're going to wrap it up with the million-dollar question, Dr. Fazil. Should we continue testing? Should we back off of our testing? Or should we increase our testing?
So I will call it a billion-dollar question. And the reason is, like, any test we do it for a reason, unless we're doing an epidemiological study. Otherwise, from intervention point of view, if we do a test and there's no follow-up, there's no treatment, then we're just wasting our money. For example, if we do the test, the results should be available rather quickly, so we can do the intervention. For example, quarantine the patient if it's positive. The test has to have a rather good true positive rates, less false negative, less false positive rates, and then in addition we should also be able to do contact tracing, so we can prevent this epidemic from more spreading. Now, what we have seen so far, that's not happening. You do the test, sometimes take it weeks to come back, sometimes it's come back weeks after it's false positive, false negative, and then there's no follow-up after that test is being done. Patients have no clue what to do next after the test is given to them weeks after they've been tested. So in realistic world, that should have been done. The results should have been available immediately. They should have been quarantined if it's positive. It should be real positive, and then there should be a mechanism in place to see who they got contacted in last 14 days, so they can do the contact tracing and test them, and if they're positive, they should be isolated as well. But unfortunately, that is not happening. That means we're doing the test, which are a lot of time is false positives, and then the data is also skewed because if the patient is tested twice, it is reported as 2 cases instead of 1 cases. And then also, if you do a blood test and it has immunity to the COVID-19 because they got exposed but they get recovered and then have immunity, they're also being reported as positive. So I think it's causing more of a fear factor than doing any real good at this time. I would focus on the testing, and I will say do more testing only when you have the plan in place. Let's say what you're going to do next after the test was positive or negative, which would be either you treat the patient or you do quarantine the patient and then do the contact tracing. And if you cannot do all these 3 things, then we should only do the testing when patient has imminent respiratory failure. I don't see any need, medical necessity for doing testing for heck of it, So I think we should wait for the test to develop, wait for the treatment to become available, and wait for the vaccine to be available. So instead of using our resources in testing, and not doing everything, and just making numbers and causing lockdowns and financial shutdowns, I think we should focus on finding the treatment and then finding the right vaccination, and then after that, testing will make more sense. But right now, I don't think putting a lot of focus on testing is doing any good to us in any way. We do know it spreads mostly through respiratory modes. Social isolation is still recommended, and use of mask. I think we should focus more on those 2 things, and then just wait when you get the vaccination available and treatment available, and the test become more accurate and rapid response available, then go ahead and start doing more testing. But at this point, I think it's causing more of a fear factor than doing any good to us, to our communities, or to our economy.
This concludes our August 2020 edition. Thank you so much for joining us, and thank you, Dr. Fazil, for joining us as well.
Thank you so much, for having me in this show today, and thank you, our audience. So stay tuned. We'll be back next month with more updates. So stay healthy and stay safe.